So my name's Chris Benovich. I'm an adult gerontology clinical nurse specialist for geriatric services at Methodist Hospital. And I have the pleasure of introducing our first speaker today is Dr. Marie Boltz. Dr. Boltz is an Eloise Ross and Robert Eberly Endowed Chair and Professor in the Penn State College of Nursing. Dr. Boltz provides instruction to both undergraduate and graduate nursing students and serves as Associate Director of Translation of Best Practice for the Center for Geriatric Nursing Excellence at Penn State. She is a fellow in both the American Academy of Nursing and the Gerontological Society of America. Dr. Boltz serves on the Board of Directors of the Gerontological Society of America and the National Hartford Center for Gerontological Nursing Excellence. With extensive clinical, administrative, and research experience in primary and community-based care, acute care, and long-term care, she is a board-certified gerontological nurse practitioner and licensed as a nursing home administrator. Dr. Boltz's areas of research focus on the geriatric care environment, including measures of quality, dementia-capable and family-centered interventions, and the prevention of functional decline in older adults. She presents nationally and internationally and has authored and edited numerous journal publications, organizational tools, and chapter books, including the evidence-based geriatric nursing protocols for best practice. So please help me welcome Dr. Boltz.
Thank you, Chris. So when you heard acute care, long-term care, home care, all these settings and places and people I've connected with, it just means I'm an old nurse. Okay. I've been around a long time and have been very privileged to work with older adults for decades, and started out as a nursing assistant like Terry. And I was thinking last night about my decision to work with older people, and it happened actually when I was in high school, and I was working as a nursing assistant in a nursing home, not a very high resource nursing home. I want to make sure I can see you all. I accompanied one of the residents over to the ER, and the hospital was close by, and it was the end of my shift, and this resident was very afraid. She had advanced dementia. I didn't know that then, but I knew that she couldn't understand things and was contracted and had a pressure injury. And I remember going into the ER and seeing how the staff treated this woman. And there was a dichotomy between people who, were so tender and caring with this person, as well as a physician who, described her in a pejorative term and said, get her up to the floor. And I was so angry at that person, so angry. And for a few years, maybe more than a few, I carried that judgment with me about people who didn't love older people and saw them as different and saw them as problematic. And what I came to realize is that that physician who spoke in a pejorative way and acted in an unkind way was probably feeling unloved himself, or untended and uncared for and afraid and maybe not very well prepared or stressed. So I came to realize, as Terry, As Terry pointed out, that really when we talk about caring for older people, we're talking about a community of care. We're talking about staff, we're talking about caregivers, we're talking about patients/residents, as well as the organization. And so that's why my research moved in that direction. How do we work on developing models of care that support best practices? So it's a beautiful day in Omaha. I'm really grateful for that. And Omaha is very beautiful. And thank you for inviting me. Thank you to the committee that asked me to attend today. So I'm talking about these intertwined pathways to health and well-being in older people, mobility and mentation. And often we separate the two, not just with older people, with people in general. And there's a problem with that because they're so interconnected. Mobility impacts mentation, mentation impacts mobility. Our interventions need to address both. Our assessment needs to address both. And I'm going to touch upon some things regarding that today. Now, I'm preaching to the choir and why there's a geriatric symposium. The gall of me to tell you about demographics. But this topic is important because declines in cognition and mobility are big predictors of outcomes. If there's a decline in one, usually there's a decline in the other, and they predict things such as ongoing functional decline, care dependency, other issues with caregivers, hospitalizations, utilization of services, costs, et cetera. Also, the most important reason is it's important to older people themselves. They repeatedly say, what I want to do is to continue to walk, or if I can't walk, I want to be able to get out of my wheelchair into my garden. I want to be able to think and clearly interact with other people. So this is what's important to older people, and that's why we focus on it. So what I hope to do today is to just talk a bit about the 4Ms framework and its relevance to age-friendly approaches for patient and family-centered care, and describe some evidence-based approaches to support positive mentation. And when I talk about mentation, I like to think of it more as the mind. It's not just cognition, but it's a sense of well-being. So I prefer the term actually mind over mentation in terms of 4Ms. And I'll also like to talk about some strategies for safe mobility and how important it is to integrate what matters into mobility and mentation plans. So though these may not be explicit, they're very implicit in what I hope to talk about today. And you're all familiar with the 4Ms. And bottom line, what it is assessing these 4 dimensions and going beyond that and developing a plan. And what I see in practice often is there's the assessment, it sits in the EHR, but then there's difficulty creating that plan. And my research most recently has focused on working with family members, care partners during hospitalization to develop a plan. And it's been a challenge. So there's this bi-directional relationship. So looking from a physiologic perspective, what do we see? We see the cognitive function influences gait and balance. People who have some trouble thinking, have some trouble with wayfinding, they often have trouble with gait and balance. Probably in many ways because they continue to move without recognizing that they're tired when they can't find direction. Also, physical activity improves brain function. So we know that physical activity is the single most important protective function against cognitive decline. And we know that when there's a decline in one or the other one follows. So when we're hospitalizing, when we're working with hospitalized older adults, we often see that they become delirious and the loss in cognition stays with them in the post-acute period. So the physiologic reason for that is within the prefrontal cortex, there's a dual role in executive function and motor planning. So cognition, executive function, and very key with motor planning and acting upon that motor planning. And the hippocampus is associated with navigation and memory, so hand in hand. Also, the neurotransmitters impact both systems. So there's a physiologic reason why we're here today. So why focus on mentation? Number one, depression I see repeatedly in my hospitalized older patients. It is very common in older adults. 1 in 3 hospitalized older people also experience delirium. Who in here works in acute care? Who works in long-term care? Okay, community-based care and other. So there's a wonderful mix. And what you see with our older adult patients is that we need to stop thinking in silos about hospitalized patients and home care patients and think just about the patient, because their comorbidities and also any type of challenges related to cognition and mobility follow them. So we need to constantly be thinking of the here and now, and also where they go from here and now. The number of people with dementia in this country is astronomical. All cognitive issues negatively impact the risk of falls. 1 in 3 people over the age of 65 fall every year in this country. And with that, it's commonly associated cognitive decline. It also impacts hospital readmissions and longstanding functional decline. So let's start with depression. Is the older person depressed, and how can we help? So one of the things that we emphasize with our patients and also with our family members and our students is that this is not normal aging. You know, the person who is slow moving or who appears sad or appears what we might consider befuddled, this is not normal. And it also is not normal that when a person is admitted to a nursing home from the hospital or from home, that they experience depression. Depression is pathology. It's not dysphoria. It's not a grief response. And the consequences are significant. Pain is worse. There's difficulty recovering physically. There's a worsening of drug side effects, and also poor nutrition is the sequelae. And it occurs in terms of major depression and up to a fifth of our nursing home residents, and is also common in primary care. And we often fail to detect it because of medical illness, cognitive decline, social and economic problems. Why else do you think we fail to detect depression? I'm looking for my social work colleague. Yeah.
Well, I think we spend less time with our patients. We're so focused on tasks. We don't have the time to get that one-on-one time and pick up a feel as to where they're actually at.
Right, absolutely. So we value and prioritize efficiency. So definitely. Any other reasons? Yes.
I think, we just have a view of what aging is that needs to change, or it's changing, but slowly. It's a little bit like, well, of course they're depressed. They're old.
Absolutely.
All of that, like, what do they have? Some of that's in there, I would say.
And what is your name?
Oh, I'm Diane.
Diane. Yeah, okay. Thank you for saying that. A big reason we fail to detect, and actually any of the 3 M's, is ageism. We have a preconceived idea and low expectations of what is associated with aging. So ageism is a really common reason. And Terry, you were going to say something.
Just the lack of LMAPs or even psychiatrists, psychologists,
Right.
especially in rural areas.
Right. Lack of access to resources, including medical practitioners. So depression tends to be long lasting. It's associated with somatic symptoms and agitation. I teach my students, you can't think of depression looking the same way in an older person as a younger person. And often it's the younger person who says, oh, this hurts, this hurts, this hurts, this hurts. And that's the key sign of depression. It needs immediate attention in order to promote the efficacy of medication and other treatments. And it's found in these high-risk groups that people with comorbidity, people who have dementia, people who have vascular disease, neurodegenerative diseases, sensory loss, personality attributes such as low self-efficacy or pre-existing anxiety disorder, personality disorders, life stressors, and social stressors. We also know that it's one of the primary risk factors for dementia, as well as being often a harbinger for dementia in later life. So people who do have significant depression often go on to live with dementia. So I was trying to think of how we could, there's this big push within the 4 Aims framework. And I'm going to be frank and disclose to you my feelings on the 4 Aims. I am so appreciative that now we have a framework within the acute care setting and long-term care and home care to address quality issues. And I really think the value of the 4 Aims is around quality improvement. Do we have the assessment and do we have the plans? But in some ways, it sort of presupposes that everybody has the same knowledge of care of older people. I'm Chrissy smiling. And I'm saying this because I'm so grateful that we have people like Chris and that Nebraska Medical Center is doing the work that it is doing in geriatrics, which is really about educating us in general about the needs of older people. Because if we don't have that, we can't implement any type of 4Ms framework. I don't know if anybody wants to chime in on that, but I just feel the need to say that in appreciation of the work you do, plus also the recognition that when we want to act on these 4Ms, we need to step back and say, does staff have the knowledge to conduct a cognitive assessment? Do they even know what cognition is? Are they able to safely assess mobility? And do they know how to safely move people? And do they understand the relationship with nutrition and sleep and continence, you know, the things that us old timers grew up on, knowing as geriatric syndromes. So I thought about like how we can assess what matters. Is there a loss of interest or pleasure in what's important to the person? Have there been recent losses or crisis? I look at the mind. Is there a history of depression or change in cognition or depressive symptoms? Is there diminished concentration, which could also be a sign of delirium? Are there feelings of worthlessness and guilt or suicidal thoughts or some dramatic signs such as psychosis? And then moving on to the other M of mobility, is there a decreased level of functioning, loss of energy, psychomotor slowing, or agitation? You know, oftentimes I see, especially in long-term care, people who are pacing, you know, and are called agitated, a term I don't like, but are called that because they're upset and moving quickly. It's actually a sign of depression. And are there hallucinations? And looking at the mobility, is there a decreased level of functioning, fatigue, loss of energy? I already said that. It was a long flight and I'm tired. Thank you for laughing. And then medications. Are there any meds that cause depression? And here's some of the common offending drugs that are associated with depression. And the one that I like to point out that is often missed is the H2 antagonists, the beta blockers, and also some of the immunosuppressants and cytotoxic agents. I mean, we know that antipsychotics and benzos are up there on the list. So AGS, in terms of strategies, has told us what some of the indications are, what are the best practices for starting antidepressant medication. So I included this in your slide in case it's helpful. But you can see that in people who show a 5 to 9 on their PHQ-9 score, if they're not currently treated, we rescreen them in 2 weeks. And if they are treated, we try to optimize their antidepressant dosing. And then we move on to a major depressive disorder, starting antidepressant therapy when their PHQ-9 is 10 to 14. And for a major depressive disorder, we definitely want to start antidepressant therapy and make sure that there are the supports provided by counseling, by social work, by psychology. Now, people who have dementia, as I said, have a higher risk for depression. It's estimated as high as 68%, and we're well aware of that in people who are in the early stages of dementia, who are really, feeling, that they're not able to cope, and the grief that they're experiencing moves on to depression. It is not due to the usual changes in the brain that one sees in an otherwise functional brain. So that what I'm saying is that there are actual other changes within the brain when the person has dementia. And it is thought that the depression can be associated by the actual neurofibrillary tangles and plaques and cerebral atrophy, the shrinking of the brain. And it can manifest itself differently. And so it's recommended, by the Cornell scale, where we're looking for symptoms of depression. The person isn't able to report somatic symptoms, but we look for mood-related signs. We look for behavioral disturbances, physical signs such as appetite loss and weight loss, and also the cyclical function of it. The fact that symptoms are often worse in the morning and then they get a little better throughout the day. And then there can be ideational disturbance. Who is the demographic cohort that you're most worried about, who is depressed, God bless you, who could commit suicide? Who is that demographic cohort? Anybody? Older males who have a drinking problem. So older males who have trouble with alcohol, they're the population that is most at risk for suicidal ideation. Now, how do we manage it? Of course, counseling and behavioral interventions. We definitely want to stay away from the tricyclics because of the anticholinergic effects, which include falls, worsening confusion. We recognize that it may require up to 12 weeks to achieve therapeutic effects. If the person has executive cognitive dysfunction, that is if they have trouble finding their way, or they can't manage directions, or they can't manage the checkbook anymore, they're going to be more resistant to medication. So the person who fails clock drawing, they're going to have more trouble. We're going to have to be more diligent and more aggressive monitoring them. Exercise reduces the depressive symptoms, and we need to attend to nutrition, elimination, sleep patterns, physical comfort, and pain control. That's why I say, we really rely on our geriatric experts like Terry and Chris and you in the room to help staff understand the interconnectivity with the whole person. We want to get people to set goals, and we want those goals to be measurable, and we want them to be meaningful. So if the goal for the person is to walk their dog, they love walking their dog, that might be the goal. Or getting to the soccer game might be the goal for mobility, so that the person can see their grandchild play soccer. So let's look at a case study. This is actually a real person. She's 80 years old. And she comes to the primary care setting and says that she's achy and fatigued and hurts all over. They should be red flags or something to us. And she missed her appointment 2 weeks before. She didn't show up. Do you recognize this person? So she was a caregiver to her husband, who died of complications of dementia 3 months ago. Her daughter lives close by. She's not met with friends for over a year, and she has help come into clean. She does have some support. She has a history of hypertension, hyperlipidemia, high cholesterol, mild CHF, stress and urge incontinence, hearing loss, CJD, anxiety, bilateral cataracts, and wears corrective lenses. So she has a significant amount of comorbidity. She takes an ACE inhibitor, Lasix and Lipitrol, Detrol, Tylenol arthritis, Xanax, and Tylenol PM. She wears the Depends due to stress and urge incontinence. She has less social contact. She eats cookies and snacks all day. I relate to that. She naps a lot. I don't relate to that. And she's irritable. And her daughter says she's mentally slow and forgetful. And her daughter helps her with the bills because she can't keep up with them. You can see that her vital signs are, she has mild hypertension. She looks unkempt. She can walk on her own, but she clings to the walls. And she has trouble getting out of a chair. She's had a 10-pound weight gain, and her hemoglobin A1C is high. So her MoCA is normal, but her PHQ-9 shows significant or severe depression. So what are the possibilities?
High cholinergic burden, get rid of that, Benadryl and Benadryl,
Benadryl. And where's the Benadryl hidden?
Tylenol PM,
What else do you want to do?
hide or Xanax.
Hide it? Or take it yourself? Right? Anybody else?
She's isolated, so she doesn't.
And right, Anything we can do about that isolation?
Or figure out,
Get her,
we will go.
yes,
How about some grief counseling?
grief counseling. Absolutely. Anybody? Anything you want to know? Anything we didn't tell you?
Around an antidepressant, IPH.
Any hobbies, et cetera. Also, maybe get her involved in senior center, get her outside the house. So this is what matters to her, her family, her church, her physical independence, nature. So getting her out in nature, getting her connected to her church. Maybe there is a church group that she can join. Get her in a senior center if she agrees. We really want to monitor her PHQ-9, her functional status, her safety, and her glucose status. We need to get that. I don't know if anybody mentioned that, but we need to get that blood sugar under control. Exercise at the senior center to address her mobility, get her with a walking buddy within the senior center, maybe within the neighborhood. Explore new hobbies. And as you said, get rid of the depressogenic meds, the ones with high anticholinergic burden, control her diabetes, and a trial of SSRI. Now let's look at her 2 years later. She shows up at her primary care clinic and says, I'm here because my daughter told me to come. I don't really have any complaints. She still lives in her home. Her daughter Susan reports that she often has to clean out the refrigerator because there's moldy food in there. And she got lost driving to the hairdressers, but she blames it on the construction in the neighborhood. But she did go 15 miles out of her way before getting help. And her daughter's keeping up with her bills and managing her calendar full time. She says she has a little knee pain. Her appetite's fine. She's been using a cane, but she typically forgets to use it. Her clothes are now big. She's wearing a heavy sweater in mid-July and is anxious and easily upset. She's lost 25 pounds over 18 months, and she's got red excoriated areas in her upper breast, inner breast, under her breast and upper thighs. And you can see the mocha has declined. Look how she describes 11-10. There's an 11 and there's a 10, but just not in the right position. I was actually surprised at how good the number placement was. So any testing that should be done?
A UA,
What's that?
a UA.
UA, okay. Check the urine. Anything else? Right. So check her thyroid, B12 and folate levels. Anything else? Anything else you want to know? I think the history provided by our clinicians is very good. What about her meds?
It changes the last time.
Any changes, any updates, making sure that there aren't any of anything that is added, any cholinergic burden.
Taking them.
Yeah, she even taken them. What is her mobility? Yeah. What is her mobility? She has a cane, sometimes she's using it. And what would you include in her plan of care? I'm sorry,
Home health therapy.
home health care.
Social activities, exercise. You know,
Social.
the church is, I think, that's kind of important, that's a big one. There's usually a lot of functions and the pump up there, it's under is, you know, more wrong. That's the area that could be really enhanced,
Absolutely.
opportunities there.
And we'll circle back to her. As it turns out, her daughter helps her move into assisted living. And she does acquire the diagnosis of dementia. So we know that that's the umbrella term, and we know the physiological reasons. And I work a lot with caregivers, and what I try to emphasize to them is what you already know, that this is a brain disease. You know, that there are changes in the brain. And I also emphasize this with direct care workers. And we know that Alzheimer's is the most predominant dementia. So here are the meds that are often prescribed, but the reality that we're living with right now is that they are not a cure. And that's why the emphasis of our care has to be on care and helping people live with the disease and perhaps get involved in the clinical trials for Alzheimer's disease. So the evidence-based dementia care includes 4 main areas: early detection, preventing and detecting and managing complications while managing the comorbidity. So paying attention to her diabetes, to her hypertension, her other comorbidities, her sensory loss. We also want to promote mobility and physical activity, cognitive stimulation, and socialization. The third main element is focusing on function and quality of life. So is this person up moving? Is this person doing what they want to do every day? Is this person having moments of joy within their life? And it has to be family-centered, addressing both the patient and family needs. And Burns and all said something that really resonates with me, which is supporting the patient without consideration of the family can not only result in increased care or distress, but bad outcomes, poor outcomes for the patient and carer. And I would refer you to look at the CARE website on GSA, which talks about how we can proceed in detecting dementia. We want to kickstart the conversation around brain health with the person, listen for concerns, and then move on to assess for cognitive impairment, evaluate for dementia using standardized tools, and then pull in neurology, neuropsychology, and also get them engaged in community resources. So that's an excellent website if you don't know it. I use them in my practice and in my research, the AV8. Also, there's the Blessed Mocha. So we want to engage the family in that assessment, and these can be used across all settings. Now, with this emphasis of engaging family and ongoing care, we really want to provide that counseling focused on things that I described around interventions: physical activity, good nutrition, sleep hygiene, et cetera. And also, what are the resources? What I have heard from family members to be the most stressful part of being a caregiver is the fact that they feel alone. And their aloneness is centered on the idea that people don't know what they do every day, and they can't relate to it. So having the opportunity for caregivers to really expand and talk about what their daily life is like and where they need help, and connecting them with other caregivers is really critical. Advanced care planning is also critical. Now, the Healthy Aging Brain Monitor is a really great tool for those practicing in primary care and home care, because it really helps evaluate the progression of cognitive and functional impairment, including mobility, and how the person is responding to medication, and is the caregiver coping. So that's an excellent tool, and there are subscales around cognition, functional subscales, behavior and mood, and also caregiving. Now, what I've learned working with people with dementia, because this clinical part is really critical, but what I've learned, and our social work colleague pointed out, is that, ageism is so prevalent and people suffer because of that. And part of it has to do with language and the words that we use. So people who are living with dementia, when they're called demented, when they're called a victim, or they're dealing with the war on Alzheimer's disease, they're suffering, dementia is an affliction. This all propagates the sense that the person is somewhat less than they were as a person. And though their ability to function may be diminished, they're still that person. The result of this kind of language, and research bears this up, is that people experience social isolation, and also misunderstanding and lack of trust. And I would challenge us to consider that these words also impact the care partner, the family member, and the care partner suffers from feelings of being less than and low self-esteem and being disconnected. So our language is important. Now, we're all concerned with behavioral symptoms of distress, yes. And I appreciate my colleagues who use terms such as behavioral symptoms of distress rather than other pejorative terms, because it is distress that people are experiencing. We want to look for the underlying reason. We want to assess for new medical problems. Is it a UTI? Is it a URI? We want to get rid of the bad medications, address the sensory deficits, keep the environment structured, consistent, and comfortable, and home-like that cues people. You know, when I work in the nursing home and I go into a dining room and there's a lot of noise and there's music playing that, you know, is really, to some of us, you know, not pleasant. And there's the clatter of dishes and bare tables. And I say to myself, I don't wonder why the person with dementia wants to get up and leave, because there's nothing in this environment that says it's time to eat. And there's nothing inviting within the environment. It's a place to want to get away from the chaos. So the environment is key, and paying attention to eating habits and making sure food is adapted rather than feeding people, but providing fingered foods and attending to caregiver needs. One of the things that I think is absolutely critical and we still struggle to do is structured activities. You know, I work with family members that when the person is leaving the hospital, we develop a daily plan for what they're going to do every day, when they're going to get up, and down to the detail. You know, they're going to go to the bathroom, brush their teeth, do grooming, you know, walk to the kitchen, et cetera. And then they have a plan maybe to be engaged in meaningful activities such as helping with the housekeeping, breaking, you know, things that are meaningful to the person, but it is structured and it is mapped out in at least 30-minute increments. That really helps the care partner, the family member. It helps with organization also, because there's opportunities to plug in other people. So when the home health aide is coming to visit, they can help the person, take the person outside and exercise. Does that make sense? So of all the things that I think we're often more remiss on is that daily structured activities. Now, Kale and colleagues recommends DICE, which I'm sure many of you are familiar with, where we look for what the causes of the behavior, who, what, where, when. We investigate the cause. Is it a toileting issue? Is it pain? Is it fatigue? We want to treat the cause and evaluate its effectiveness. Now, this is something that I learned the hard way by making many mistakes working with people with dementia, and thinking that I was kind and thinking that I was efficient and thinking I was getting the job done. But, you know, barreling into a resident's room in the nursing home and saying, you know, being very cheerful and let's go and we're going to do this and this, and being upset, you know, when they told me to get the H out of here, but not recognizing that they weren't understanding who I was and where they were, and who was the stranger coming into their room. So I had to learn to say, I'm sorry. And it's something that I've tried to teach family members to say too, and staff. And first thing I try to say, I'm sorry, this is hard. I hate this for you. And even the person who has receptive difficulties, you know, who can't understand those words, they hear from my tone, you know, that I'm trying to let them know that I messed up and I feel bad about it. I'm sorry, it should not have happened. I remember being on a tour in a nursing home, and there were about 5 or 6 of us walking through a memory care unit within the nursing home. And one of the residents got really upset and said, you know, this is a mess, this is a disgrace, get the H out of here, you know. And I thought, you know, no wonder she's upset, you know, with this entourage trampling through our home with no announcements, you know, no introductions, you know, no context. And I went up to her with her and I said, this is my fault. It should not have happened. Also, I'm sorry, I was trying to help during caregiving tasks. Sorry, I made you upset or angry. And no right to make you feel that way. So these are the 5 things that often pop into my mind when I say I'm sorry. But it's a key response that often diffuses people who are upset so that they don't progress on to more symptoms. You're shaking your head. You try, do you do this? Say, I'm sorry. Powerful trip. So another year later, Ms. P is more confused and her daughter states she's in the hospital when she contacts you. In the ER, she's described as aggressive and agitated. Her urine's positive. She has white blood cells in the urine. They took cultures of her urine and blood, put in a Foley and restrained her physically as well as giving her Ativan. And she's admitted to the ICU with urinary sepsis. They hydrate her. Her glucose is around 150 to 80. And of course, she's CAM positive. During the first 2 days, she has waxing and waning, being upset, visual hallucinations. She's getting IV Ativan and Houndel, and she's in bed, of course. She's not gotten out of bed. And the day before she goes home, she is assisted out of bed that evening. Her restraints are DC'd late in the hospital, of course, and she has poor oral intake. And when her daughter comes in to help her around day 3 to 4, she improves. So 2 days after the hospital discharge, she says, I'm all right. Her daughter says she was experiencing falls and increased confusion in the assisted living. She was on new meds. You asked that question. But she did continue on Namenda, which haven't started. Prior to hospitalization, she was restless, unaware where she was, and called out for her daughter. Since going back to the AL, she's been a bed, except for meals, because she just looks so sick, right? People look so sick. She's on meds that she previously had been on, as well as Seroquel is now added to the regime. And her vital signs are stable. She can get out of bed with 1 person assist and walk 10 feet with a walker and 1 person. She doesn't have any focal deficits or edema. MOC is now a 10. So what do you want to do for her now? What are your priorities for her now? What would be your what do you think would be like a sort of, God, we got to get on this?
Therapy,
What's that?
therapy.
Therapy, physical therapy? Mobility is a big issue.
Getting her out of bed during the day.
Get her out of bed during the day.
Routine.
Routine.
Yeah.
Getting her to activities.
Self-care.
Yeah. Getting her to activities. Maybe a structured toileting plan, which will help with mobility on and off the toilet before and after meals.
Monitoring her blood sugar.
Right. Monitoring her medical stuff, including her blood sugar. What about the Seroquel? What? Wean her off of it, Chris. Yeah, wean her off of the Seroquel. Most people coming from the hospital who have dementia are going to be on an antipsychotic, unfortunately. So you want to wean her off of that. Anything else?
Make sure they took out the phone.
Yeah. Well, I hope it's out. Yeah. Make sure the Foley's out. And then the structured warding plan. And look at that care plan. When it says toilet every 2 hours, say nobody wants that and nobody does that. We don't go to the bathroom every 2 hours unless we have a problem. So structuring a toilet plan around her meal time and getting in and out of bed. So delirium, which is a medical condition characterized by trouble with disturbance in attention and awareness. It's preventable and under-recognized. We know the complications are tremendous in terms of functional outcomes, medical outcomes, and costs. There's impaired cognition, impaired attention, problems with arousal, and fluctuating symptoms. Now, are you familiar with the UBCAM? Anybody working with the UBCAN, which is a two-step approach to detecting delirium. Step one is asking the day of the week and the months of the year backwards. And if people fail that, they go on to the 3D CAM, which addresses for those main cognitions. That has demonstrated good sensitivity and specificity. Jury's still out in people with dementia. In terms of management, we want to ID delirium early and treat factors, prevent the complication, and get people moving and eating and hydrated. Which brings us to mobility. A lot of times we think of mobility as purely walking, and it's really the ability to move oneself, getting on and off the toilet, feeding oneself. So ADL is critical as a metric for mobility. It's a critical marker of health, and it's important to older people. Now, those of you who are working in community-based care, including primary care and home care, people are going to underreport their mobility issues because they're embarrassed by them. But we need to emphasize with them that this allows us to know what their strengths are and capitalize on them and help them be the best they can be. And some of the recommended screenings in primary care and home care are for health or physical reasons. Do you have trouble climbing 10 steps or walking a quarter of a mile? And because of underlying health or physical reasons, have you modified the way you do? So do you have the trouble or have you modified? Do you stop and rest? Do you use an assistive device? And also the report of both ADL and IADL. The recommended tool to screen for mobility is TUG, which evaluates gait, balance, and strength, use of assistive device, fall risk, and need for PT. We are slow in getting PT on board, and I regret that we are. Other tests that we use include gait speed, 6-minute walk test, chair stand speed, and we want to look at those results and track them for fall risk. In terms of promoting mobility, we assess medications that cause problems, such as the benzos, the antipsychotics, the antidepressants, and the opioids, and also things that impact blood pressure. Now, IHI recommends setting early, frequent, and safe mobility goals, focusing on what matters. Is it getting to the bathroom, walking outside? And that should really guide the plan. It also provides motivation to the person. There has to be a reason to get up and move, whether it's in home or whether it's in the long-term care setting. If the reason for me in home is to get to the mailbox, if the reason for me in the long-term care setting is to get to the nourishment statement, there has to be a reason. We also want to manage the impairments that reduce it. We know that the benefits of physical activity cut down on the multiple diseases that I've listed here. Also, there's impacts functional health, decreases the risk of falling, and improves cognition and mood and pain. The best exercises for older people include walking, and I emphasize that, walking, stationary cycling, swimming, squats, Tai Chi, arm weights, and regular stretching. I did work in assisted living and long-term care, and we take in those little cyclers and give them to people. We also use them in acute care and provide them at the bedside. And in long-term care, some of the facilities or communities that I work with announce over the loudspeaker, "Up, Sally, up," which is an exercise they use in military training where people do sit to stands, and the staff as well as the residents participate. Preferences matter. I'm a frustrated activity director. I wish I had done that, but I know that people move and stay cognitively stimulated when they're doing what they want to do. We look at ways of sneaking physical activity into routine activities. So instead of people sitting at bingo or listening to a performer, we have them pass out the music sheets. We incorporate physical activity into bingo with exercise bingo. And we want to make sure that there's opportunities to get up and move. And also those activities need to promote social and cognitive function. So they're intertwined. Now, I have a friend who you probably know who says hospitals are dangerous places for older people, right? You can figure out who it is. Probably a couple of you in the room. And we know that there's loss of muscle mass and the culprits are bed rest and lack of physical activity. What we don't recognize is this often begins prior to admission. And that we need to look back to what the baseline ADL function was, 2 weeks prior to the hospitalization before the person got sick. We know that this often persists, this hospital-acquired disability following discharge, and fewer than half of people get back to their baseline. Now, are you familiar with the JHAMP assessment? Anybody in here? Okay, do you use that, Chris?
Used to be that.
Okay. It's really a systematic approach where the organization says we're prioritizing mobility and we're going to evaluate it in our QI and we're going to hardwire it into our HR and we're going to measure it clearly. When I did research with nurses, they said, we don't prioritize mobility because our nurse manager doesn't care about it. We don't measure it. So it's prioritized. Get rid of the barriers such as lack of equipment, hallways that are cluttered. Look at roles, who's doing what, education and training. How do we integrate mobility into the workflow? And how do we give feedback to the staff nurses and other people around how well we're doing in terms of assessing people and following plans? And also having signage and other things that promote, we are about keeping people mobile and functional and active. The JHLM score helps you set goals based upon the assessment of mobility. And this can happen by nurses with support and oversight by PT. And you can see there are different levels. Now, the evidence on structured exercise in acute care is not good. So people have attempted to bring together older people and help them exercise. And there's been problems with feasibility, of course. People are sick, they can't get to the exercise, so there's high attrition. And the results are sort of mixed on it. And we don't really know if they lead to differences in function or harms. They may decrease length of stay, but it might be that these are high-performing hospitals too, who actually are doing exercise. And it may reduce costs. But these are the results of a systematic review. Now, nurse-led mobility protocols have better results. And by nurse-led mobility protocols, I mean where the nurse is assessing the person and developing a plan and helping people be mobile. And we don't have many studies, as you can see here, only one RCT, and the rest were sort of quasi-experimental. But the findings revealed that older people who participated in mobility protocols or mobility programs were walking more, mobilized more, and that includes getting on and off the toilet, and that there was some reduction in length of stay. But we definitely need more studies and hope you participate in that. We also have looked at unstructured mobility programs. So not programs that are really focused on setting goals, but are all about messaging, increasing awareness, educating staff, educating families, and some environmental modification. Unstructured mobility interventions in general medical units improved function and physical activity, but we need more studies. So I challenged us to consider, we know it's good care. The studies will follow so that we can convince our leadership around the need to deploy people better, or maybe have an extra person who's a mobility coordinator. But we need to keep doing it. In critical care, they're actually ahead of us as compared to medical units using the ABCDEF protocol, which again looks at symptoms, pain management, detecting and treating delirium, and getting people up and moving, and including the family in that. And the results are very promising in that, in terms of decreased delirium and less ventilator days. Now, I've done work with function-focused care, which really is a philosophy of care, which says instead of doing everything for people and doing things around people, we help the person do for themselves. And in order to implement that kind of philosophy, there's 4 components where we look at the environment and policies. You know, does the environment support mobility and cognitive stimulation, or does it encourage people not to move? Do the policies encourage people to continue to be in bed? Do we have a policy on eliminating indwelling Foley catheters so people aren't tethered? Are we getting rid of tethers consistently? It also includes goal setting with the person, measurable goals, education of everyone within the community, staff, patients, family members, and mentoring. Having a champion who mentors the staff and says, atta girl, atta boy, you know, and let's figure out a ways that we can get this person out of bed and moving. The results have been positive and pretty dramatic in nursing homes as well as in assisted living, where there's been improvement in function, also improvement in physical activity. And in assisted living, there was a decrease in fall rates and also a lower rate of transfers to the hospital. Excuse me, lower rates of transfer to the nursing home. And that's all I'm going to say. Any questions on function focused care? There's a lot published on it. Now, I adapted that intervention for acute care, but pulled the family into that because prior work with patients in the hospital demonstrated that people want to be mobile if it's important to the family members. And if the family member has an incentive wherein there'll be less care dependency, or I can go back to work and leave them with the caretaker during the day or leave them safely at home, I'm going to encourage them to move. And also families played a key role in encouraging the patient and also helping with goal setting because they know the person and know what motivates them and know what the baseline function is. So again, we look at the environment and we look at the policy, anything preventing this from happening. We provide education to staff, and the core component is the FAM path, which is a jointly developed care plan between the nurse, the patient, and the family member. And it looks not just at mobility and cognition, but all the things that support that, such as nutrition and sleep. And most importantly, we take that plan and we follow people home for 2 months in the post-acute setting through weekly contact. Initially, it was in person, and now it's via telephone. And we modify that plan. And we found that this is important because it promotes a sense of well-being and cognition. And it also is aimed to decrease unnecessary functional loss. We educate families around the importance of encouraging self-care and what are some of the activities that promote mobility. Family members can't remember complicated exercise program, but they can remember things such as having the person vacuum or rake, even if it's a small area, you know, fold towels, which you do in the nursing home. Many, those of you who work in the nursing home, use a horseshoe game. Dancing is key, helping the person stand up and move and dance, gardening, and also meaningful cognitive stimulation, you know, looking through the photo album, you know, speaking to family members that are important to them. And this is an example of one of what I described as the structured plan for the day, with morning, afternoon, and evening. Now you can see some of the things that are highlighted really promote physical activity, taking a walk, playing an active game, gardening, dancing, cleaning up the kitchen. So it can't just all be, you know, being nice and being cognitively stimulated. We got to infuse the physical activity within that. And what our outcome showed is that families felt more prepared when we did this. So we used the preparedness scale. We looked at goals, and there was increase in goal attainment. And most importantly, goal attainment was directly correlated with delirium abatement. So people had less delirium and less hospital readmissions. And we also found that people returned to baseline function at 2 and 6 months when compared to routine care. A new finding that we were surprised by, that we did not expect, but we measured, was that there was less delirium and less behavioral symptoms of distress that occurred, new delirium, and also less behavioral symptoms of distress, probably because of our attention around that, structured daily plan. And what did the family members say they need help with? So we interviewed them and said, so did we do okay? What did we need help with? Well, one interesting thing they told us was that they didn't like the way we described things, and they didn't like some of our measures. So they didn't want to be called caregivers. I'm a daughter, I'm a wife, I love my spouse, I love my father. That's who I am, and this is what I do. Don't be using that term caregiver. And of course, it's all over the tools we use. They thought our tools, we measured burden and strain. What else do we do? Burden, strain, and forget the third thing, but they said they're all negative. Why don't you evaluate some positive things? So now we measure things such as relationship between the person with dementia and the family member. And is it improved or does it remain stable? And we also evaluate quality of life for both members of the dyad. They said that what was important was staying connected with people and also managing behavior. So psychosocial support, managing symptoms was important, knowing how to detect delirium. So we taught them how to use the FAM-CAM. Physical activity, helping activities, sit to stand exercise, leisure activities. They also thought it was important that we help them advocate. They knew how to talk to the doctor and say, this medication he's had in the past and it's bad. So advocacy was important. And they also, again, said caregiver stress, helping to deal with that was important and getting them connected to services. So we know that with mobility and cognition, there's sort of parallel assessment. So there's more and more attention paid to evaluating gait speed as a brain vital sign, because gait speed is predictive of cognitive decline and mortality. Also, we know that there is a motoric cognitive risk syndrome, which is really significant cognitive complaints and got accompanied by slow gait speed. The person is having trouble with thinking and also they're moving slow. And that's now been established as a pre-dementia syndrome. So something that you want to pay attention to in your practice. It's associated with an increased risk for Alzheimer's and mortality. And also there's more attention paid to dual task testing, where we walk with people while asking them to perform a cognitive task, such as naming animals. And that reveals early cognitive dysfunction, which is particularly predominant in vascular dementia. We also are able to predict falls and dementia risks because we walk and think at the same time. So here's some combined interventions: dual task exercise, such as dancing while counting, cognitive motor therapy, and PT and OT. And we found that there's greater benefit when we do them both together. Also, virtual PT and cognitive sessions are effective. Apps are gaining more predominance around gait tracking, memory gains, med-props, and it reduces the barriers for rural and mobility limited patients. I work with some rural patients, and this is critical. The Finger study showed that physical activity and cognitive training slows decline, so we need to combine them both. The Life study includes mobility training, which reduces disability and cognitive loss. And there's more and more new trials on dual task training. And we're measuring that by people wearing devices that monitor physical activity and other indices. Another important thing to consider is that Medicare now supports mobility and cognition screening. So those of you in primary care, you can get paid for it. Bundled payment models reward function-focused care now. And these incentives align with 4Ms and value-based care. So here's my key points. Mobility and mentation are deeply intertwined. Decline in one accelerates decline in the other. We assess and intervene and support across settings. 4Ms provides a practical framework, but we got to go underneath it, and dig deeper. There are gaps in long-term care studies on combined interventions. We don't have diverse populations except for my acute care study, which did. We don't have many studies with diverse populations. And we don't integrate primary care and rehab into these interventions enough. So we've neglected primary care and rehab. So there's a call to action for us to screen and intervene early. Care teams need to combine assessments and take a rehab approach. When we're admitting somebody with the hospital, we should have a rehab mentality instead of just focusing on the acute admitting problem. Organizations are going to adopt the 4Ms across settings, and policymakers need to be encouraged to support funding for integrated care. So what are the future directions? Hopefully personalized care using AI and wearable tech, dual domain programs that focus on mobility and mentation, and building some evidence for it, 4Ms, because the evidence is really, really slim.
Would you share your thoughts on the bed share alarms in relation to policy mobility?
Wow. I'm going to make some friends and I'm going to make some enemies. Bed and chair alarms largely don't work because they tell you that somebody's on the floor. And I hope we know that somebody's on the floor before the alarm goes off. So if we're using them as an intervention to prevent falls, it's just ridiculous. Also, there's a lot of evidence around bed and chair alarms causing distress and behavioral manifestations in the person. So I'm not a big fan. One of the things that we do with our QA data is we look at the fall rates and we say, oh, they're good, they're bad. And it doesn't tell us the whole story. We don't go deep to say, was that a really sentinel event, that particular fall, that really needs to be addressed? Or what were the reasons, why people fell? I do a lot of quid pro quo. I try to make deals with people when I'm doing research, and help them with their magnet and help them with their other things and around performance improvement. And people were upset because their fall rate was happening. And when we looked at the data, when it was happening at like 9 to 11 at night. What do you think was happening at that time of day? CNAs were totally not with the residents, totally off the unit. And we're doing things like housekeeping things. And when we pulled them back on the unit and changed the plan to support toileting, the fall rate went down. And that's why it's really key that we have to include the whole team, including the nursing assistant, within the analysis of data. They said, well, I know why that's happening. Could have told you that. All right, well, thank you very much for your attention.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.